Hello dear students, can you hear me? Hello dear students, can you hear me? Dear students, welcome. We are here for INICET June session being done. Today, 19th of May, we had the INICET exam, and in this particular session, we'll discuss the questions in biochemistry and microbiology in a single shot. Uh, how was the exam? Let me tell you in simple words. The clinical questions were actually less, but one-liners were high. And for the general population or the people who took the exam, they believed that it was a very easy question paper. And many people would have actually had the idea that if we had prepared well, we could have actually definitely gotten the best of ranks. Now, let me start the whole session by saying only one thing. Throughout the years, since 2009, when I actually went for my first INICET equivalent called as AIMS exams, this is the trend. In case of AIMS, when AIMS conducts the exams, the question paper will be extremely easy. It will feel very easy to begin with. And when you come out of the exam hall, in the first 2 hours, you'll feel like, oh my God, there is a very good chance I can get a seat. And even if you have prepared very moderately well, it will boost your confidence very well in such a way. It will make you feel as if there is a very good chance you'll get the seat. That is understandable. But as the time progresses, as the number of hours elapses, you'll start realizing the simple kind of mistakes that can happen. AIMS has the simple trick of making sure if they change the is from the previous question into was, the past tense to present tense or present tense to past tense, the answer changes. If they had changed from is to are, that is a singular becoming plural, the answer changes. That is the level of the smaller amount of changes that can actually implement, because of which the answers can change. So without wasting much of time for today's session, let us see as many questions as possible. Now look at this question. This was the simplest of question possible. Now I had 4 options to be given. 2 options were told by the students because many of them did not understand what exactly were the remaining options, because they understood the right answer. The answer is that if at all any case of cellular information transfer, what is the sequence in which the cellular information can happen? Moment please. So whenever a ligand comes and sits on the receptor of the cell, the ligand is supposed to be the first messenger. Remember this if you have not given much of thought to it. Whenever I speak about first messenger, second messenger, third messenger, etc., what is the first messenger? That is when a ligand comes and sits on the receptor, that ligand itself is the first messenger. Now as you go into the second messenger pathway, imagine this. First, adenylyl cyclase is the enzyme that tries to convert ATP into cyclic AMP. Now this cyclic AMP is a second messenger, which will in turn activate protein kinase A. Now you can have protein kinase A, protein kinase C, etc. So if you have to arrange them in the order, it should be adenylyl cyclase, which will give rise to cyclic AMP. When it is increased, it will activate the protein kinase A. This is the sequence of events I would want you to, or cyclic AMP, which activates protein kinase A. This is the sequence of events I would want you to understand. Oh, thank you very much. So now this is a very simple question. Now have a look at this. Here also we have, this is an example picture. Adenylyl cyclase converts ATP into cyclic AMP, which will give rise to protein kinase A that is capable of inhibiting or activating anything in the sequence. So in this system, for any kind of example for that matter, any cell for that matter, in general logic, in case of flow of information inside the cell, it starts with adenylyl cyclase giving rise to cyclic AMP. Cyclic AMP will have an effect on the protein kinase A. Now let's look at the next question. This is pharmacology plus microbiology coming together, but let us assume only the biochemistry part. Now these are all will be discussed in case of pharmacology chapter. But in case of today's session is biochemistry and microbiology, and we'll be having subsequently 3 more days of continuous sessions where we'll discuss about the INICET. Please try to watch all the sessions so that you will understand what kind of questions you got in today's exam and what kind of questions will have smaller kind of impact in the bigger exams like NEET exams. So when you go for the NEET exam, you should be able to understand what is the current trend of question paper setting. Now, the antidiabetic medication that can cause UTI is SGLT2 inhibitor. The SGLT2 inhibitor can be dapagliflozin, canagliflozin, etc. Gly is glucose, flow is flow of the urine, zin is inhibition of the same. Now, when you look at SGLT2 is mostly concentrated in the renal tubules. Here you can introduce microbiology, you can introduce even biochemistry and pharmacology in one single shot. How does a UTI happen? Let me tell you this. When SGLT is in action, remember it is sodium and glucose having a co-transport. Now, if this is the receptor, only when sodium portion of the receptor and the glucose portion of the receptor are occupied, they'll be able to transport the sodium into the target. At this point of time, you have to realize one thing. Here, you can think of this, sodium and glucose will go together. Now, when you try to inhibit the sodium glucose co-transporter, you will be having natriuresis because you are not absorbing sodium. At the same time, you're not absorbing glucose. So, you can have glucoseuria. Now, glucoseuria and natriuresis both can happen when SGLT2 is inhibited, and this SGLT1 is present in the GIT. SGLT2 is in the renal tubules. When the sodium and glucose co-transporter is inhibited, sodium is also not absorbed or reabsorbed, glucose is also not reabsorbed, both of them are excreted. And when the renal tubules are continuously seeing glucose flowing through and through and through, as the glucose is flowing, it feels as if a patient who is diabetic, where extraordinary amount of glucose is flowing through the kidneys. So that would mean to say that the local renal inflammatory immune responses will be affected because of the poor amount of this diabetic situation where you're not able to handle the glucose coating of the renal system will increase, because of which advanced glycation end products will happen. This can prevent any kind of attack from your immune response onto the bacteria present on the GUT, genitourinary tract, because of which the E. coli, which is the most common commensal in the urinary tract, and rare organisms like Klebsiella are all capable of becoming dangerous in the advent of excess amount of glucose traveling through the renal tubules. Okay, now let's look at this question. Did you answer this question, students? Hi Abhishek, Surinarana, Narendra sir, Gaurav Tripathi, Satish, Vandagappe. I hope you're able to see this. Yes. For those students who went for this exam, they would have had 2 MCQs about acid-base balance. I repeat, there were 2 MCQs related to acid-base balance. Yes, thank you, Ved Kamat. So there were 2 MCQs related to acid-base balance. Now this one is a case of diabetic ketoacidosis. Some students said the pH value was extremely less. Some students said the pH value was almost normal. Now, can you please tell me what kind of question did you have? Was the pH value normal or it was less? Good evening, Aniket. Good evening, Meghna. Tell me, what was the pH value? Was it less or high? What was the pH value? Anybody? Okay, no matter what it is, they had to look for high. Now, the pH value 7.34. Yes, Aniket, it should be enough. But if you go for Harper, it can actually take a lot of your time. Please go for Vasudevan's textbook of biochemistry. It should be able to help you. Now, have a look at this, because whatever questions you got in INICET today, you can easily answer them using Vasudevan. You can trust it. Tell me what was the pH given today? See, the pH, if it was 7.34, it is not mild. It was not actually acidic at all. It was okay. But assuming if the patient has DKA, there are three things you have to understand. Yeah, Vedkant. So if this is around this value, please understand they are trying to tell you that the diabetic ketoacidosis, the pH is not abnormally seen. Now, the DKA can be either mild, or it can be moderate, or it can be severe. If it is moderate, can you have a look at this? If it is moderate, the plasma glucose levels in all conditions can be more than 250. Whenever glucose levels have come for 450, when glucose levels have come for 450, it can actually be a case of type 1 diabetes mellitus giving you rise to DKA. Now, what is the point you have to take forward? If it is type 1 diabetes mellitus, it can most commonly give rise to DKA. If it is type 2 diabetes mellitus, it can most commonly give rise to hyperosmolar hyperglycemic state. Now, in case of DKA, the ketone bodies will be formed, because of which acetone in the breath can be noticed. Now, what is anion gap? Now, currently the anion gap has been replaced by SIG, which is strong ion gap. But in simple terms, anion gap is equal to the combination of sodium and potassium on one side, subtracting the combination of chloride and bicarbonate on the other side. So sodium and potassium on one side, chloride and the bicarbonate on the other side. Some authors say that potassium need not be taken. So sodium, if it is approximately 135 to 145, I take a midpoint of 140. If it is chloride, I take a midpoint of 100. If it is bicarbonate, I take a midpoint of 26. So 100 plus 26 is 126. Sodium is 140. Now, approximately anion gap can be 14 to 16 if I go by this number. Otherwise, it can be between 8 to 12. Now, in this case, or the case that was given to us, the sodium levels were high, or sorry, very low. The potassium was slightly on the other side, and chloride, they don't remember. They said bicarbonate was around 20, but when they calculate the anion gap, it was 29. If the anion gap is between 8 to 12, it is normal anion gap. If it is less than 8, it is low anion gap. If it is more than 12, and if this in this case it is more than 29, it is high anion gap. But because it is DKA, you call it as acidosis. So because it is acidosis, you take the value as, good evening Mula Mani Kanta. So because the pH value is not actually helping us, we assume it is diabetic ketoacidosis. Because of that, we go for high anion gap metabolic acidosis. Now, what kind of questions are raised in this topic? See, high anion gap metabolic acidosis will happen in cases of accumulation of ions or accumulation of acids. For example, in case of methanol poisoning, this is for your NEET PG exams, please make a note of this. You can have methanol poisoning. Methanol will get converted into methanal, which is formaldehyde. That will get converted into formic acid. So formic acid is acid accumulating, because of which again there will be high anion gap. You can have uremia in case of kidney failure, diabetic ketoacidosis where acetone, acetoacetate and beta hydroxybutyric acid can be formed. Paraldehyde poisoning can be seen, which can also become acids. Or you can simply go by the mnemonic called as mud piles, where I is for ischemia, L is for lactic acidosis, E is for ethylene glycol poisoning, and S is for salicylic acid poisoning. In all these conditions, when acids are accumulating, including diabetic ketoacidosis, you have to go for high anion gap metabolic acidosis. Now, some people have asked me, then where can I get normal anion gap metabolic acidosis? The two most common things are ureterosigmoidostomy, where the contents of the ureter are not reaching the bladder, instead they are going to the sigmoid colon, because of which you may have loss of bicarbonate. At the same time, you can have diarrhea, where again you will have loss of bicarbonate. Here you don't have accumulation of acids, but there is loss of bases, because of which you have acidosis. Now, what is LAGMA? Low anion gap metabolic acidosis. The best example for that condition is bromide intoxication. Now these are the most common things that have been asked in the recent past. Know these answers for any kind of question related to high anion gap, medium or normal anion gap, and low anion gap metabolic acidosis. Now look at this question. This is a similar question in terms of acid-base balance. Yeah, similar question in terms of acid-base balance. Can anybody confirm these numbers? Can anybody confirm these numbers? See, it was the second case on acid-base balance. So whenever you come for case history based activity, you should be knowing one thing. If at all they speak about a patient having metabolic changes because of which H plus ions are massively elevated or bicarbonate ions are decreased, you go for metabolic acidosis. For example, in case of poisoning. Now, when will you have metabolic alkalosis? Intake of bases or loss of acids. For example, a patient is very severely vomiting. Because of vomiting, he loses HCl. In that condition, the patient can go for hypochloremia. That hypochloremia can be a reason for alkalosis. So in this condition, if you give chloride, if the alkalosis is becoming better, then it is chloride responsive alkalosis. In spite of giving chloride, if it is not getting better, it is chloride resistant alkalosis, but both of them can contribute to metabolic alkalosis. I'm just giving you clinical scenario where vomiting can actually lead to alkalosis. Apart from that, when you go for a respiratory statement, the best example for a clinical picture that tells you is in case of respiratory condition, if a patient is going for hyperventilation, there is excess washout of carbon dioxide, because of which excess washout of carbon dioxide means PCO2 will fall, because of which you have alkalosis, respiratory alkalosis. Or if a patient is suffering from opioid poison or he has crush injury of the chest, because of which the breathing has come to a halt, because of which carbon dioxide washout is decreasing, so carbon dioxide is increasing. So when carbon dioxide washout decreases, that can lead to acidosis. In this picture, they had not spoken anything about. They had not spoken anything about the history is what the student said. So pH is 7.5. If pH is 7.5, it is alkalosis, point number 1. Now, bicarbonate was also elevated. PCO2 was also elevated. This was the complaint given by the students. The students said that bicarbonate was also elevated and PCO2 also was elevated. Now, how will you say which one it is? Now, if bicarbonate is elevated, it will lead to alkalosis, of course. If PCO2 is elevated, it should have led to acidosis. Then what is the condition here? Here, the primary disturbance is bicarbonate, which is rising, direction is upward, which is causing alkalosis. But the secondary compensation will be PCO2. What is the rule? Whenever there is a primary disturbance, the secondary compensation has to happen the same direction as the primary disturbance. So the primary disturbance is bicarbonate, the secondary compensation is PCO2. So PCO2 also should rise. This is the thing that you have to expect. So PCO2 is elevating. Now the student said the PCO2 value is approximately not understood or not known or not remembered. Can anybody tell me what was the PCO2 value? Does anybody remember what is the PCO2 value? It is okay if you don't remember the PCO2 value, but how much should be the PCO2? So in case of metabolic alkalosis, HCO3 is elevating, so PCO2 also should elevate. Expected PCO2 in metabolic alkalosis should follow the formula like this. For every 1 millimeter mercury elevation of PCO2, you expect 0.6 millimoles per liter elevation of bicarbonate. Now, what is the normal bicarbonate? Normal bicarbonate is 24 or 26 and the patient's bicarbonate is approximately 50. So, there is an elevation of 24. Now, that would mean to say that for 1 millimeter, it should be 0.6. For 24 millimeter, it should be 24 into 0.6. 6 4s are 24, 6 2s are 12, 14. So you can expect 14.4 millimoles per liter elevation of bicarbonate. I'm so sorry. This is for the acidosis. In case of acidosis, the PCO2 is elevating, because of which the HCO3 also should elevate. Now, if HCO3 is elevating, what do you expect? What do you expect? So we have a case in hand. One is metabolic acidosis, the other one is metabolic alkalosis. If we assume this is a case of metabolic alkalosis, the primary problem is bicarbonate elevation. If bicarbonate is elevating, PCO2 should elevate. How much PCO2 elevation should be seen? That is what we are discussing right now. So here you will be having, for 1 molecule of PCO2, that is, sorry, 1 millimole per liter of bicarbonate elevating, 0.6 millimeter mercury of PCO2 should be elevating. So in this case, the calculation is the same. You have to add 14.4. It means instead of this, you have to have 14.4 added to the normal value of PCO2. So PCO2 normal value is 40, and here you add 14.4 to it. So 54.4. If at all, in the case, if PCO2 was given, and if the PCO2 given was around 54.4, then the compensation is adequate. If it is less than 54.4, the compensation is not adequate or under compensation. But if at all the value was less than 40, then that is a case of mixed acid base disorder. This is what you have to ask yourself for. This is what you have to ask yourself for future exams. Now, what you can expect in case of NEET PG is, they have given you the case. This is metabolic alkalosis, where bicarbonate is elevated and PCO2 is also elevated. That is what the case was given here. Now, in this case, they didn't ask you whether the compensation was adequate or not, but I am telling you how to calculate. You can follow this calculation, and this calculation is right. You will be able to go for this, and in that position, that patient's PCO2 should be 54.4. Now, you can have 4 clinical picture. If the PCO2 of the patient is still at 40, 40 is normal, compensation has not begun. If it is somewhere between 40 to 54.4, then the compensation is just trying but still has not reached. But if the compensation is 54.5 or above, then it is going for overcompensation. But what if the PCO2 is traveling the opposite direction? If it is less than 35, it means it's a case of mixed acid base disorder. This is what you can expect in the upcoming NEET PG exams. Okay. Now, for those students who have joined just now, have a look at this. Here, they have asked you, find A and B in the Lineweaver-Burke plot given. Here, look at this. I'm just putting forward both the cases here. I'm putting forward both the cases here. On your left side, you have competitive inhibition on top. On your right side, you have uncompetitive inhibition on the top. And at the bottom right side, you have pure non-competitive inhibition. So, in case of competitive inhibition, please try to look for this arrow mark. Here you have y-axis having the velocity and x-axis having the substrate concentration. But what is Lineweaver-Burke plot? It is called as double reciprocal plot. It is a double reciprocal plot. What is double reciprocal? In a normal kind of graph, we have velocity versus substrate concentration, right? Here, you go for both the things into reciprocal. It means to say that now in this particular graph, you can have the y-axis governed by 1 by V and the x-axis governed by 1 by S. Now, in case of a normal enzymatic action, you will be looking at it, but now you will be having 1 by V versus 1 by S. Now, this is the inhibited arrow mark. This is the uninhibited arrow mark without any inhibition. Now, if you look at this point, the x-intercept you see here is, come on, Mullah Manikanta, yes. Can anybody tell me what is the x-intercept? Anybody? Come on, people. Yeah. See, in a normal graph when I'm trying to draw here, if this is the activity of the enzyme, now here you will be having the velocity as 1 by v on the y-axis and the substrate concentration on the x-axis. The point where this particular line touches the x-axis is referred to as minus 1 by km, and the point where the same line touches the y-axis is 1 by velocity. Now this is the 1 by V max that you are looking for. So maximum velocity has been in this position and minus 1 by km is in this position. Now let me show you a different kind of color. Now in this color you will be able to notice that this has attacked you in such a way. The minus 1 by km has moved from here to here while the 1 by V max is remaining the same. So from this you have to understand, in a Lineweaver-Burke plot, in case of competitive inhibition, what can change and what will not change. When there is a competition for an enzymatic action, let me just put them, this is the last part of the explanation. If this is the enzyme and this is the active site of the enzyme, now here the substrate is supposed to come and bind. Instead of the substrate, if another inhibitor is coming and binding, now the inhibitor is taking the place, substrate has been knocked out. If you want to reverse it, you increase the number of substrate molecules, because of which you can knock off the inhibitor. So mostly competitive inhibition will be reversible. Competitive inhibitions are reversible. Now as this happens, if at all you look to add the substrate into the local equation, you can always get back the original function of the enzyme. So enzymes nature is not lost. See, this is for you to learn them very beautifully. Enzymes nature not lost. But what happens in case of non-competitive inhibition? It is going to act as a poison for the enzyme. Because it's going to be a poison to the enzyme's property is lost. Because of which the Vmax of the enzyme can come down dramatically. But in case of competitive inhibition, the Vmax is unaltered. It means the enzyme's nature is not lost. So Vmax is retained. The only thing is, because the inhibitor was sitting here, it was not allowing the substrate to come and bind, because of which the attraction between the substrate and the active site has decreased. It means the Km value increases. That means the minus 1 by Km value decreases. So remember only one point to look at it. In any kind of graph sheet, if the Vmax is unaltered, then that is competitive inhibition, because the quality of the enzyme is not altered, but the binding of the enzyme to the substrate is decreased, so Km value increases. This is a case of competitive inhibition. Now if you want to look at non-competitive inhibition here, have a look at it. Here you will be able to notice one thing, that is minus 1 by Km value is not altered here, but the Vmax is decreasing. If you look at it here, you'll understand one thing, that is the blue colored line is uninhibited. It is touching the y-axis at a lower level, and the red line is touching the y-axis at a higher level. But higher level means what? 1 by Vmax is higher. If 1 by Vmax is higher, Vmax is lower. So because of inhibition in case of non-competitive inhibition, because of non-competitive type, the 1 by Vmax is increasing because of inhibition. It means Vmax is decreasing. So Vmax decreases non-competitive. This is the point here. 1 by Vmax increases. It means Vmax decreases in case of non-competitive inhibition. Now let's go for the next question. They have not told us the exact kind of answers. Which of the following is known for causing stool inhibition? So if you have an idea, please let me know. Now look at this picture. Does anybody remember this from your exams? Can anybody confirm? Can anybody confirm this picture was seen or not? Okay, so Some students said that coffin lid appearance was given. Some people said that appearance was not actually explained. The picture was shown. So they said the urine with a pH of 8.4. That is what was told. The urine had a pH of 8.4. It means alkaline urine. Can you give me a microbiological cause of an alkaline urine? It can be because of UTI caused by urease positive infections. Can you give me example of a urease positive infection? Anybody? Can you give me an example of a urease positive infection? See, Staphylococcus aureus or Proteus, both of them are capable of causing a urease positive infection. What does a urease do? It tries to break the urea and liberates ammonia. So when ammonia increases, the pH will increase. Now, what is the golden point that you have to remember about alkaline urine? If the urine is alkaline, if there are any acids that are going through the tubules, they will become ionized. If they are ionized, they become more soluble. And if they are more soluble, they will be lost in the urine. I would want you to remember this concept for the rest of your lives. Whenever the urine is alkaline, then if you place any kind of compounds in the tubules which are acidic in nature, then under alkaline condition, the acids will become ionized. Ionized compounds will become soluble. And when they are soluble, they are lost in the urine. So they are not retained in the tubular parenchyma. So acidic stones do not happen. Acidic stones formation is very poor in case of alkaline urine. In alkaline urine, acidic stones formation does not actually be support. So here you understand this is a pH of 8.4. Uric acid is acid. Calcium oxalate speaks about oxalic acid. Oxalic acid stone formation also will become less frequent. But here you look at ammonium. Ammonium salt formation can actually be happening very easily because the whole medium is alkaline. Ammonium is also alkaline or ammonia is alkaline. But the best answer will be triple phosphate stones coming out in the urine, which will have the coffin, that is a box in which a dead body can be placed, coffin. Have a look at this picture here. This is the coffin lid appearance. The coffin lid appearance is a property of, triple phosphate stones. These are also referred to as struite stones. Struite stones have the coffin lid appearance. Now, what are the other kinds of things that you can see? This is the coffin lid appearance in different forms. This is a type of coffin lid appearance. This is a coffin lid appearance. This is a coffin lid appearance. This is a coffin lid appearance. This coffin lid appearance can be multiple things coming together. Now, what are the other crystals that you can see? Now, this picture is taken by Microbiology Online or Notes page. Thank you for that page. Have a look at this. This is uric acid crystal. Uric acid can actually form crystals in a polymorphic fashion. This is an MCQ. Now, look at cystine crystals. Cystine crystals are monomorphic. Watching cystine in the urine is not normal. Watching cystine in the urine is not normal. And that cystine is an abnormal crystal and this can have a hexagonal shape. So this is monomorphic and have an hexagonal shape. Triple phosphate, these are the triple phosphate which look like the coffin appearance or coffin lid appearance, which can be seen in alkaline urine with a pH of more than, with a pH of more than 7. Now look at this. If you look at calcium oxalate, if bihydrated or monohydrated, the calcium oxalate bihydrate crystals are colorless pyramids of various sizes and shapes which can have a simple name called as envelope. Some students had given me an answer saying that, sir, the image looks like envelope. I chose envelope and that is why it was calcium oxalate. See, have a look at this. It looks like the Google Gmail sign. Do you remember the Gmail's icon which looks like this? Or it looks like this. This is how the picture looks. So if it is envelope shape, it is calcium oxalate. If it is coffin lid shape, it is triple phosphate. Okay, now there was a question and about biochemistry where they spoke about post-transcriptional modification or post-translational modification. Aniket Tigga, please ask me those questions at the end of the session. This is for INICET recall session. Please tell me. You can also ask questions in microbiology here. Try to answer the biochemistry questions from here. Okay. Can anybody tell me whether it was post-transcriptional or post-translational? Some students said it was post-translational. Some students said that it is post-transcriptional. But if it is Aniket Tigga, which app are you speaking about? Because in Manipal MedAce app, we have gone only through systemic approach, and those organisms who are exactly belonging to all the systems have been placed in a different kind of setup, saying that specific microbes. I repeat once again, in Manipal MedAce app, it is not like any other app. We will be having a systematic approach. So please download the app, Manipal MedAce app, and see the videos for yourself. Here you will be having in Manipal MedAce app, you have videos framed based on the systems only. Cardiovascular system, respiratory system, blood, RS, GIT, GUT is how we have framed them. Have a look at them when you have time. Now for those people, if it is post-transcriptional modification, what are the things that you have to know? Splicing of mRNA, and you have 5' end, 3' end. To the 5' end, it is 7-methyl guanosine being added, which is referred to as capping. To the 3' end, you are going to add multiple adenylyl group, that is called as poly A tailing. So on the 5' end, you have a cap. Now there are some places where mistakes can happen. Some students have said, yes sir, 5' methylation has happened. No, it is not 5' methylation. It is 5' end having a 7-methylated guanosine getting capped. So you will be having the cap that is happening and the methylation happening on the 7th carbon of the guanosyl group. So remember, 7-methyl guanosine is getting capped, while on the 3' end you have polyadenyl tailing, you have splicing of mRNA. Some people can add RNA editing also into the equation, but these are the post-transcriptional modification. Now look at this part. When it comes to histone mRNA processing, it's a very complex topic. Please remember, in case of histones, H2A, 2B, 3 and 4 will be forming the core of the nucleosome, thus are called as core histones. So when it comes to mRNA, you will be having a different concept as in other conditions. But in case of histone mRNA, it is slightly different. If it is a core RNA, look at this area here. The typical histone mRNA lacks several features of other eukaryotic mRNA. Now, because of which they don't undergo splicing and their 3' processing is done independent of most cleavage and polyadenylation factors. The core histone mRNA have special stem loop structure, a 3' end. This is what you have to remember. Okay, now when you have post-translational modifications, you can actually divide them and classify them into, yes, you can divide them into different types. You have addition of chemical groups, which is reversible. You have amino acid modification, which is irreversible. The cleavage will be irreversible, and addition of polypeptide is also reversible, and you can have reversible addition of complex molecules. All these are post-translational modification. Let me give you a simple example. If you have a proline residue of the collagen getting converted into hydroxyproline, then this hydroxylation is an example of post-translational modification, which is an example of reversible post-translational modification. So let me concise them once again. Hydroxylation, phosphorylation, acetylation, methylation, they all can be reversed. Dehydroxylation, dephosphorylation, deacetylation, demethylation can happen. So these are all post-translational modification. Now again, AMPylation, ADP addition, glycosylation, prenylation are also reversible. But what is irreversible? Removal of an amide bond is irreversible. Elimination is irreversible. Proteolysis, the protein itself is destroyed, that is also irreversible, which comes under cleavage. And addition of ubiquitin or UBL protein subconjugation, they are also reversible. All these are examples of post-translational modification. They said the question was like this. So one of them was 5-methyl capping. 5' guanosine capping is an example of post-transcriptional modification. Everything else was post-translational modification. Now, what is the answer for this question? Which of the following is seen in Korsakoff psychosis? See, Wernicke-Korsakoff complex is a syndrome. They are asked for multiple options, it seems. A, B, C, D, A, B, C, B, C, D, A, C, D, A, B, D, all these things were asked. So in that, amnesia is having lesser frequency of appearing in Korsakoff psychosis because this is psychosis, while Wernicke is encephalopathy. You can expect encephalopathy to show you amnesia, but not psychosis. So in that aspect, remember, confabulation happens in Korsakoff syndrome. Confabulation means creating new memories in those areas where memory gaps are seen. For example, if I try to draw this, look at this part. If I try to draw this and I ask you it resembles which letter, most of you will say it may resemble U, or you may say it is resembling O. Now, if at all I left it here, you assuming it as U is fine. If I left it here and you assuming it as U is fine. But if I draw it till here and I miss it out, this small space you don't actually consider, you ignore it and call it as O. Why? Because your memory was able to fill the information here, because of which calls it as O. So whenever, because of psychosis where there is elimination of some kind of information, you can actually create new memories. That is called as confabulation. And there is a simple mnemonic. Yeah, there is a simple mnemonic called as Goa MP. In case of Wernicke-Korsakoff syndrome, where there is a severe B1 deficiency. Yes, thank you, Vinay. Now look at this. G is global aphasia. G stands for global aphasia. O stands for ophthalmoplegia. A stands for ataxia. Ataxia, ophthalmoplegia, global aphasia. Then we have memory loss, or it can be present as mental retardation, or polyneuropathy can be noticed. So this is seen, this is seen, this is seen, but amnesia is generally a property of encephalopathy. You know the answer for malaria species identification, so let us not discuss much. Now, heme breakdown, which is not an end product. Heme breakdown is in such a way, heme is converted into biliverdin. Heme is a tetrapyrrole ring structure with the iron at the center. Now when you break it, the ring, if it is supposed to be like this, when you break it, one of the methylene bridges are broken, you will be able to get a structure like this. This is linear tetrapyrrole. What you are seeing here is a linear tetrapyrrole structure. That linear tetrapyrrole is biliverdin. Now in that process you have an enzyme system called as heme oxygenase system. In that you will be liberating carbon monoxide, one of the carbons is lost, and you will be using the laws of ferrous ion. And so ferrous ion, carbon monoxide can be liberated, biliverdin can form. But what is about the delta aminolevulinic acid equation? Delta ALA is the product of the first step of heme synthesis. What is the first step of heme synthesis? Succinyl CoA plus glycine in the presence of ALA synthase is referred to as, will give you delta aminolevulinic acid. So remember, option 3 belongs to heme synthesis pathway, not to heme breakdown pathway. So the right answer is this one. Which of the following things cause familial hypercholesterolemia was asked, and I do not know all the remaining options. For those people who know, please tell me. But if it is familial hypercholesterolemia, it is type 2A. In case of type 2A, if this is the liver and the blood is traveling through the liver, on the surface of liver cells you will be having LDL receptor. If the LDL receptor is mutated, then the receptor is not able to accept the LDL. Through the LDL, cholesterol is not entering inside, so the cholesterol stays in the blood, because of which you'll be having hypercholesterolemia. So LDL receptor defect can be taken into the equation. If you have any questions, you can ask me about this. Which combination is used as an antidote for cyanide poisoning? See, whenever there is a cyanide poisoning, this is the treatment. You can have hydroxycobalamin, which is hydroxy vitamin B12, and sodium nitrite and sodium thiosulfate. This combination should be given. Now, the students said that they did not find hydroxocobalamin in the equation. Am I audible, students? Is this visible? There was a transient disconnection from the internet. Are you able to see it? Okay, we are back live. Let's have the completion of the session. We have amyl nitrite, sodium nitrite, and sodium thiosulfate that can be taken into the equation. And hydroxocobalamin, if it is given, that is also a right answer. It was not given in the question as what student said. It is given as an IV infusion, and so it can be demonstrated or given by quality or qualified healthcare professionals. Okay, now what about the fish? Does anybody know the answer to this question? This was a recent question, repeated many times. Fish cannot detect what? It can easily detect deletion, amplification, translocation. The only thing it can't do is point mutation. This is an important answer. So let me actually help you with this topic faster. Let us do it in a very faster manner. See, this is the picture of fish where you'll be able to see the chromosome here, and the fluorescence can be noticed. Fluorescent in situ hybridization is what you expect. This is an example of fish being studied. Now, why fish cannot detect point mutation? Now, these are the 4 points you have to remember for the future. If they tend to ask you the same questions in the future, you should be able to know. First one is resolution limitation. Here, you have to understand fish is designed to detect large scale chromosomal abnormality. For example, if there are deletions of a chromosome, amplification seen in chromosome, translocation seen in chromosome, you will be able to see them. But if you look at point mutation, which involves the change in a single nucleotide base pair, then it is too small for detection by this method. Apart from that, look for the probe design. You need a probe to read for fish, right? Fish probes are usually large DNA sequences. Probe means what? You send something and try to elicit the presence or absence of something else. A probe means it's going for an investigation. Now that probe will be generally large DNA sequences that hybridize to specific regions of the chromosome. Detecting a point mutation would require a probe that can distinguish between the sequences differing by just one nucleotide. Now it means you have to create, for example, if this is a probe where you're targeting the exact complementarity here, you have to create a probe which will exactly know that deletion only, that point mutation only when you can create a probe of that manner, when there is a mutation here or the point mutation here, it is able to do it. So probe designing is extremely difficult for point mutation using fish. Also, if you go for signal detection, the hybridization signals in fish are based on the presence or absence of fluorescence. Detecting a point mutation would require a differential binding of a probe that emits distinct signals for mutant versus wild type sequences. So you mean to say one probe is supposed to go for the wild type, the other one is going for the mutant variety, and you will be able to elicit a signal here and a signal here. These two signals have to be extremely different, and you have to go for a thing that is capable of identifying that difference. Okay, now if the point mutation cannot be identified by fish, how will you actually solve it? You can go for Sanger's sequencing method, or you can go for next generation sequencing, and allele specific PCR also can be done. These are 3 methods by which you can counter the defect or disadvantage of not having to use the PCR. I mean the fish method. Okay, now these are the steps by which how fish can work. Let us do it in a different session. Now, what are the limitations of fish? See, fish is a targeted test, limited number of probes. In the next exam in the future, if you have any question related to this portion, you should be able to answer. Fish limitation, it is a targeted test, limited number of probes can be used at one time only. And remember, metaphase fish and interface fish are two types of fishes you can do. If it is a metaphase fish, it is capable of identifying the positional information. The nucleotides, when you're actually having a probe being discussed as a long DNA segment, you will know exactly where things are located. So positional information can be given by metaphase fish, but it requires cell culturing techniques to perform it. In case of interface fish, no positional information can be given, and it is labor intensive, experienced analysts are required. Now look at this. What else can you do? Micro duplication may be detected, but it can be with less sensitivity. And if a patient is having uniparental disomy, it cannot be identified by fish. Remember these things for your exams. And these are the requirements for conducting a fish. And these are the advantages of fish. Now we have seen the disadvantages of fish. What are the fish uses? It aids interpretation of karyotyping and arrays. Point number one, it can help you with karyotyping and arrays. Metaphase fish can give you the positional information. Interface fish can be performed on FFPE slides for tumor material. At the same time, it can help you with whole genome ploidy. What is the thing I said? Here, if at all you look for uniparental disomy, it cannot be identified by fish. But if you want to go for genome ploidy changes, it can be done by fish, and it can also detect mosaicism. Okay, what is the answer for this question, anybody? If it is a post-transcriptional modification, the answer is this. Which of the following is not, then it is this. If you are asking for which of the following is a post-translational modification, these two are post-translational modification. This is post-transcriptional modification. Okay, this was a very simple question in microbiology. This was a very simple question in microbiology, where they had asked about single stranded DNA, single stranded RNA, double stranded RNA, double stranded DNA. Let me tell you this. All RNA viruses are single stranded RNA viruses. All DNA viruses are double stranded DNA viruses. Now every rule will have an exception. Now when you look for the exception in case of RNA viruses, there is a Rio viridae group. In that, rotavirus is also a part of. Rotavirus belongs to Rio viridae group, which is a double-stranded RNA virus. And when it comes to double-stranded DNA, you will be having a parvovirus, which acts as an exception, which is a single-stranded DNA virus. So SARS-CoV-2, like any other RNA virus, is a single-stranded RNA virus. HPV is a DNA virus. DNA viruses are double-stranded DNA viruses. Parvovirus is an exception, so single-stranded DNA. Rotavirus is an exception, double-stranded RNA. I hope you will be able to use them. And what can be the extra information that you can actually expect in rotavirus? Rotavirus is made up of 11 segments of double-stranded RNA, which encodes 6 structural and approximately 6 non-structural proteins. Remember that. Okay, next question. What is not a characteristic of parvovirus? What is not a characteristic of parvovirus? Remember, of all the parvoviruses, parvovirus B19 is the only one known to attack humans. It is the only one known to attack humans. Parvovirus B19 is known to attack humans. Now, when the parvovirus attacks the human beings, it attacks progenitor immature RBCs or progenitor erythrocytes. And on that basis, if the patient is having immunosuppression, it can become very dangerous and can cause pure red cell aplasia. That is true. And it is capable of causing transient aplastic crisis when a patient is having hemolytic anemia also. It is capable of causing hydrops fetalis, but it is known for causing fever. But these are exanthematous rashes. They are not petechial rashes. They can cause networks, which are reticulate rash. And that reticulate rash is referred to as slapped cheek appearance. Slapped cheek appearance. I hope you will be able to remember this for your exams. Okay. Now they had asked, choose the incorrectly matched combination. Chickenpox is known to have cytopathic cytoproliferative effect, but syphilis is known to have purulent and suppurative was the option. So when there is an immunosuppression, the patient may not show much of a reaction. That is expected. In case of chickenpox, it is capable of causing cytopathic changes expected, but in case of syphilis, the differences that you see are not purulent. Syphilis is not a purulent disorder. Remember that. It is not a suppurative disorder. Okay, not a polysaccharide vaccine. What is it? Not a polysaccharide vaccine. See, in case of bacteriology, we have vaccines extracted from the capsular material if the organism is capsulated. If the organism is capsulated, it can actually be having the capsular material that has been extracted for the vaccine formation. But in case of certain kind of bacteria like Bacillus anthracis, the capsular material is made up of polypeptide. In case of Yersinia, it is made up of a fraction of a protein. But in all other most situations, the capsules are made up of polysaccharides. So if it is Haemophilus influenzae type B, if it is pneumococcus, meningococcus, they come under the majority of polysaccharide capsules. And if you want to know what exactly is in case of Haemophilus influenzae type B, it is PRP, polyribitol phosphate capsule. Remember this, it is polyribitol phosphate capsule, which is also a carbohydrate capsule. But what about hepatitis? If it is hepatitis B, it is a subunit vaccine, which is using the subunit combination of HBs antigen. So this is not at all related to the polysaccharides. So this is the exception. Okay, rotavirus vaccine, which is a wrong statement. See, you cannot start primary vaccination after 6 months of birth is not true, because rotavirus is the most common cause of traveler's diarrhea in children. And in case of adults, among virology, it can be Norwalk and calicivirus. But I'm not very sure about this option. Please tell me whether they asked you about you cannot start primary vaccination after 6 months of birth or less than 6 months of birth. Which one? Can anybody confirm this? Let us stop for just 30 seconds. Please tell me whether it is correct, whether this question is correct. See, of course, there are two types. One is pentavalent, the other one is monovalent. That is what they say. Rotatec, which is RV5, and Rotarix, which is RV1. There are two types of rotavirus vaccines, which are pentavalent and monovalent. And they are given orally. These two are correct. I just want you to tell me what this is. Is this option right? See, it is given in 3 doses. It is given at 2 months, 4 months, and 6 months. Anybody knows this? Okay then, so we'll continue. Okay, there was a question with respect to G6PD deficiency, which is false. They had a statement saying that in patients suffering from G6PD deficiency is more common in females. It is X-linked disorder, so males will be affected. So being common in more in females is not the right answer, but definitely it can cause hemolysis, and NADPH synthesis will actually decrease. Synthesis of NADPH decreases in case of G6PD deficiency. And there was another question. This is a very commonly repeated question. A baby has Kernig sign positive, and the signs of meningitis are actually present. And the mother says, the freshly born child, mother is saying that she suffered from painful genitalia lesion 1 year ago, which resolved on its own. A painful genital lesion, which can lead to meningitis, should make you think of herpes simplex virus 2. Remember, herpes simplex virus 1 usually hits above the belt, and herpes simplex virus 2 usually hits below the belt. Usually, I'm not saying always, it usually. So when you look at oral lesions or lesions on the face, etc., or anywhere, or labialis, it has to be through HSV1, 70% cases, and 30% cases by HSV2. When it comes to genitalia lesions, 70% is HSV2 and 30% is HSV1. So here, that lesion could have actually spread to the child. That is the reason why the child is having meningitis. So this can be a case of HSV2 meningitis. Remember, when it is a viral meningitis, it always is atypical meningitis. And is herpes simplex usually known for causing meningitis? Herpes simplex virus is not known usually for causing meningitis. It is known for causing encephalitis. Encephalitis. It is known for causing encephalitis. It is known for causing encephalitis. It is temporal lobe encephalitis. Okay, this is a very easy question. Which of the following can make the child susceptible to catalase positive organism? Catalase positive organisms will speak about their fight against NADPH oxidase enzymes active through the macrophage and neutrophils of the human beings. In the human immune response, NADPH oxidase can be defective in chronic granulomatous disease, because of which a catalase positive organism will be dangerous. Now, when a catalase positive organism is able to destroy the catalase, it means it can actually knock out the hydrogen peroxide. But if an NADPH oxidase is actually defective in the human being, then he won't be able to load the organism with H2O2. So H2O2 will become manageable for the organism. If NADPH oxidase is very powerful, if it is present, then you will be creating a load of H2O2 where the organism will not be able to handle. So if this is defective, the H2O2 will become easy for the catalase positive organisms to manage. So for example, Staphylococcus aureus, MTB, Pseudomonas, Burkholderia, these kind of organisms who are highly aerobic can become deadly for the human beings. It is not the common SCID or hyper IgE or Wiskott-Aldrich syndrome. Remember, in Wiskott-Aldrich syndrome, there is eczema, which can be a very important diagnostic feature. Okay, now this question is very simple. In case of newborn investigations, what is the best way to go for detection of all kinds of inborn metabolism? The answer would be tandem mass spectrometry. Which is false about ABO antibodies. See, there was a question that inherently present at birth, IgM type. ABO antibodies are IgM type, and if you want to look at the structure of the ABO antibodies, the ABO antibodies or ABO antigens, the ABO antigens are carbohydrates in nature. How? You will be having different kinds of residues also to be shown. Let me show you this. See, the ABO blood group antigens, if you look for, this picture is from ResearchGate. Have a look at this. Here we have galactose, galnac, R, fucose. So if at all you look at type O, you will be having a look at this. Now what is the difference between type O and type A? Type O does not have the galnac, which is attached to gal, and type B is having gal instead of galnac. So all these are carbohydrate components. So remember, that is a normal thing. So ABO antigens are carbohydrates in nature is true, and antibodies are present according to the presence of according to the absence of antigens or presence of antigens. It matters when they say the antibodies are present according to the absence of antigens. For example, if A antigen is present, then anti-B antibodies can be seen, not the anti-A antibodies, right? But they are not inherently present at birth. Why do I say this? See, when a human being is born, he does not have that is, when a baby is born freshly, it does not have a blood group. But depending upon the intestinal bacteria, the antigens reach the circulation after 3 to 4 days at the maximum, and in a matter of 1 week, the blood group of the child will be decided forever. So the intestinal bacteria are the reason for the antigen seeping into the circulation against which the antibodies can be formed. Remember that portion. Hypogonadism, sexual maturity, the answer would be zinc. Zinc deficiency can directly attack the gonads. Zinc deficiency can attack the gonads, and when the gonads are not properly found, sexual maturity may not be expected. Copper deficiency can be seen in multiple ways in case of infection fighting or in case of fatigue. Now the question was about how copper deficiency can cause fatigue. Copper is important for cytochrome because of the presence of the copper in the heme. Iron is also present in the heme. Iron is also a part of catalase. Now, copper is also important for tyrosinase enzyme, which is important for pigmentation. So, albinism or absence of pigmentation all can be because of copper deficiency. Iron deficiency and copper deficiency together can cause fatigue because electron transport chain does not work. Selenium deficiency can cause Cachan and Cachan-Bach disease as they have been acquired from China. So, these can also cause inflammatory status. Remember, selenium will be supporting vitamin E. This is called as vitamin E sparing effect of selenium. So when selenium is in good content, vitamin E deficiency does not occur, or even if it is less, it does not actually matter much. But zinc is purely known for hypogonadism. There is another question. Chromium. How does chromium affect the metabolism? Chromium deficiency will lead to poor glucose tolerance. Chromium deficiency can lead to poor glucose tolerance. This is an important MCQ that can be expected in the upcoming exams. Now, in case of zinc deficiency for a consistent state, there is a condition called as acrodermatitis enteropathica. It attacks two parts of your body apart from the gonads. How, if it is acrodermatitis, the tips of the fingers or the areas of your body where pressure is being taken, in those areas will be having inflammation, so painful, and the GI epithelial cells will go for very faster sloughing, so absorption can be affected. Malabsorption can lead to zinc deficiency. Zinc deficiency will cause enteropathica. Enteropathica will lead to again zinc deficiency because of poor absorption of zinc and other kinds of nutrients. So here in this question the answer is zinc. Now, the student said that the classical features of dengue were given: high grade fever, body pain, and retroorbital pain. These were actually exhibited, and the patient presents to the EMD. They said DHF was suspected. The question itself said dengue hemorrhagic fever was suspected, and that was the history of 5 days of fever, right? So 5 days have elapsed. Now the most important key word here is 5 days. This can lead to a lot of confusion getting resolved. See, if they want a definitive answer, you can go for either culture or you can go for RT-PCR. RT-PCR is highly sensitive while culture is specific. RT-PCR is sensitive while culture is specific. But now they are not looking for the best investigation or the confirming investigation. What they are looking for is the next best step of investigation. What is the next step? See, there is a confusion between NS1 and IgM. Let me clarify this here. See, after first 5 days of illness, you go for immunoglobulin M through enzyme-linked immunosorbent assay. Now here, which and when definitive test to use? Dengue NS1 antigen test in general and direct virus detection methods are used to obtain an early definitive and serotype specific identification if it has been for less than 5 days from the time of onset of fever. This is taken from NCBI papers, so you can trust them. See, less than 5 days from the time of fever onset, you can go for NS1 antigen detection or you can go for virus detection methods. Directly virus can be detected. Now, NS1 antigen testing can be conducted fairly rapidly and at a lower cost than other methods such as viral isolation. If you want to isolate the virus and then you want to culture or you go for reverse transcriptase activity, they're all costly and it takes some amount of time for that to happen. But NS1 antigen testing can be a rapid test. Now, ordering a dengue NS1 antigen assay within the first week of symptom onset is one of the initial investigations that has been recommended by the Ministry of Health Singapore. High levels of NS1 antigen were also found to be correlated with higher levels of viremia and thus could potentially be a predictor for severe illness. Now, if you go for dengue, IgM, IgG, it can actually fetch you an answer. 1 minute. Okay. See, when you go for dengue IgM or IgG serological test can be done by ELISA. And when that is happening, you are looking for the tests that are the choice after the first 5 days. I repeat, the dengue, IgM, IgG are the test of choice after 5 days of illness. So in the later stages of illness, after that, very late, dengue serology is more useful as NS1 antigen remains detectable. That is, once you cross 5 days, NS antigen may not actually be very visible. So because they can become negative, you can go for IgM. So distinguishing between primary and secondary dengue is often not done in the primary care setting. Remember that. Okay, what are the other things you have to know about NS1 antigen? Have a look at this. NS1 antigen is glycoprotein. It is synthesized by all flaviviruses, which can be arboviruses. Most evaluations of NS1 antigen assay mirror each other, indicating a moderately high sensitivity and very high specificity. Okay, these are the ABO antigens. I missed this picture in the previous one, so I had copy pasted this picture later. So have a look at this antigen. Among these two, this one is the O antigen, right? Now to the O antigen, on the galactose molecule, if you add galactose, it will be group B. If you have added N-acylated galactose, it is group A. So these are all carbohydrate antigens. Okay, now there was a question about acute pulmonary aspergillosis. This will be discussed in pharmacology for you. Have a look at this. A young purulent female in her 30s presents with mucopurulent discharge, which is green or yellow per vaginum, and an endocervical discharge sample was taken. They had mentioned it is gram negative diplococci. If they specifically mention it is gram negative diplococci, which is attacking your genitalia, then you don't have to look any further than that of gonorrhea. But in the past, if at all they had said purulent discharge have come, but the organisms are not seen much, but it is copious discharge, then you can think of chlamydia. Purulent can be chlamydia, but chlamydia is not a diplococci. It is an atypical bacteria. So remember, gram negative diplococci, gonorrhea is the answer. And how do you go for your, see, if it is trichomonas, you will be looking for a fishy foul smell. And if it is candida, it is white discharge, not green yellow, and that discharge is mostly odorless. Now there was a question. A young male who suffered from injury or had road traffic accident after a few days suffered from lockjaw. They said this was the question. What is the mechanism of bacterial action? Not all the options were given to me, but many students remember only this. Many students remember only this. Some students said they remember acetylcholine release being less, and they remembered GABA and glycine being less. Yes, of course. This is a universally asked very simple question. That has been taught to you many times. You have botulinum toxin on one side and tetanus toxin on the other side. So in case of Clostridium tetani, there are two toxins. Tetanospasmin, tetanolysin, two kinds of toxins, tetanospasmin and tetanolysin. Tetanolysin is important for hemolysis, while tetanus toxin like tetanospasmin is the reason for the spasmodic attack. Now look at this here. When Clostridium tetani comes in, it releases tetanospasmin. That tetanospasmin will go to the CNS motor neuron, where the excitatory neurotransmitter called as acetylcholine is supposed to come out. And if at all you have the inhibitory neurotransmitter called as GABA and glycine to come out. Here, the tetanospasmin will not actually have an impact on the release of acetylcholine, but instead it will try to have an impact on the release of GABA and glycine. Because GABA and glycine are not inhibited, that is not released, inhibitory neurotransmitters are not released, because of which sustained contraction happens. Sustained contraction happens in case of tetanus toxin. Then what about botulinum? Botulinum toxin causes inhibition of the release of acetylcholine. If acetylcholine release is inhibited, then it leads to paralysis, which is flaccid paralysis. So when acetylcholine release is decreased, it is flaccid paralysis. When GABA glycine is decreased, it is spastic paralysis. It is spastic paralysis. So it acts. Now there are other questions. Where do they act? They act on the Renshaw cell interneurons. Renshaw cell interneurons, and they block the release of GABA glycine. Okay, have a look at this. This can be a very nice picture to see. What you have on the top is presynaptic, and what you have at the bottom is postsynaptic. Now, when it comes to the presynaptic area, look at this vesicle. This vesicle here has been zoomed. So, this portion has been zoomed and drawn here. Now, this is the vesicle. This is the vesicular membrane, and this is the membrane of the whole synaptic cleft. Now, what you see here is the VAMP, and what you see that is attaching with the host cell, the membrane, is the syntaxin. What you are seeing here in blue color is SNAP25. So tetanus toxin acts on the VAMP portion, while you'll have the botulinum toxin, neurotoxin CAE type acting on SNAP25. These are all very important questions for your exams. Remember, for SNAP25 inhibition or SNAP25 role is botulinum toxin CA and E. If it is VAMP, it is botulinum toxin GBDF. So if at all you have botulinum toxin that blocks this area in such a way, acetylcholine will not come to the neurotransmitter, so there is flaccid paralysis. And this was the question. 24-year-old male patient which is culture positive infective endocarditis. Can you please confirm whether they have mentioned enterococcus? Some students say that enterococcus was mentioned, and they said it is enterococcal positive or gram positive infective endocarditis. If it is enterococcal positive infective endocarditis, then without any question you can go for vancomycin. Now if it is not enterococci, then that is where the question comes into equation. Now remember this, if you see gram positive cocci in clusters on the culture media, then it is vancomycin to be started 8 to 12 hourly daily to maintain vancomycin. Now if it is gram positive cocci in pairs or chains, if it is gram positive cocci in clusters, you are thinking of Staphylococcus aureus. If it is gram positive cocci in pairs, it is pneumococcus. In chains, it is any kind of streptococci. If that is the condition, go for vancomycin, ampicillin or vancomycin on an aminoglycoside if it is enterococci among the gram positive cocci in pairs. Now, what is enterococci? Enterococci is bespectacled diplococci. So gram positive cocci in chairs, if it is enterococci, go for vancomycin, which is and then go for combination of vancomycin plus aminoglycoside gentamicin. If it is just streptococci, go for vancomycin or amoxicillin, ampicillin. But if it is ampicillin or penicillin resistant, then you can't go for it. In case of vancomycin resistant enterococcal infection, you can go for daptomycin. Apart from that, you can also see these other questions. And if it is gram negative bacilli, the first line treatment is cefepime. Second line treatment, if the patient is penicillin or cephalosporin intolerant, then go for aztreonam. In the given picture here, if it is a gram negative organism, then you can think of aztreonam. And when will you go for piperacillin? If anti-pseudomonal penicillins are used, it means you have actually made an impact that it is Pseudomonas aeruginosa induced infective endocarditis. But for all purposes, in the given question, go for vancomycin. I hope this helps you. Okay. Now, this is about which of the following is the correct statement of Cryptococcus. visible to you? Okay, so I hope I'm back. See, some students thought it was a picture of chlamydia. Some students thought it was a picture of cryptococcus. If it is a cryptococcus, they are proper yeasts. Point number one, they are proper yeasts. Point number two, they are capsulated. And if you draw a cryptococcus like this, you can see a halo around the cryptococci. That is the definition of how you see cryptococci. Let me show you a picture once again. Even when you try to look at the picture of cryptococcus, that is how it should be shown, right? So when you saw a picture of cryptococcus like this, it is obviously cryptococcus, and so you don't have to confuse yourself between cryptococcus and chlamydia, because chlamydia is not capsulated but cryptococcus is capsulated. Okay, now look at this. Once you have established it is cryptococcus, remember it is a yeast and does not produce pseudohyphae, because production of pseudohyphae is a property of, oh no, sorry, I wrote chlamydia one, it is candida, that is what I meant, I'm so sorry, I apologize. See, if it is a pseudohyphae, it has to be candida. So students confuse themselves between cryptococcus and candida is what I wanted to say. So pseudohyphae is a property of candida, and CD4 count, no matter how much it does not affect the infection of cryptococcus, but the immune compromised status is the reason for the cryptococcus to cause disease. So this is not a true statement again. Now, humans only host is not the right answer, because pigeons can carry cryptococcus. At the same time, bark of the tree of eucalyptus can cause cryptococcus. Now, mainly affects the lung is a true statement. See, if I come over for a Viva session and I ask you, what is the most common disease caused by cryptococcus? What your answer would be? You would say, cryptococcus, the most common disease is meningitis. It is not the right answer. Why? Because in a group of 100 people you take randomly and sample them. Out of them, less than 10 people will suffer from immunosuppression. Remember, only when there is severe immunosuppression where the CMI has completely failed, then the cryptococcus is capable of causing meningitis. The cryptococcus can casually cause what? The most common disease caused by cryptococcus is pneumonia. I have taught this in almost all the classes. Those students who have come for this session for the first time, I haven't told you till now, just now I'm telling you, please try to download and watch the Manipal MedAce app, because we have done very extensive sessions, and if you could actually have time, please watch the Manipal MedAce crash course videos for the NEET PG exams in microbiology and biochemistry, for all the subjects for that matter. But here I have explained most important points which can come for the exams, and I have taught them so many times. Cryptococcus, the most common disease caused by cryptococcus is pneumonia and not actually the meningitis. So CNS can be affected, skin can be affected, and hyperpigmentation can be noticed because of cryptococcus. And cryptococcus also can attack your kidney and can cause nephritis. At the same time, cryptococcus can also cause infection of the bone. These are all important to know about cryptococcus. And it mainly affects the lung, because by inhalation, it actually the primary organ to accept the cryptococcus itself is the lung. Okay, this is the matching criteria they said in case of skin infections. It's a dermatology question, I believe. But if it is Tinea cruris, if it is caused by pityriasis or tinea organisms, if it is a mold, the best way to visualize a mold would be KOH mount. And what is the microbiology aspect of this? KOH is a very strong corrosive, and this corrosive is capable of destroying or dissolving the debris. When the debris are dissolved, you will be able to visualize the organism better, the mold better. And in case of contact dermatitis, you're trying for establishment of hypersensitivity reaction. So patch test will try to help you understand the hypersensitivity reaction. Remember, contact dermatitis is type 4. The most common, type 4. The most common skin manifestation of tuberculosis is lupus vulgaris, and in that condition, go for split skin test. And in case of leprosy, go for biopsy to visualize the organisms and the changes that the organisms have caused. So, in terms of, okay, I hope then Lakshmi Karthikeyan you are able to understand. Are you able to hear now? Hello, can you hear me? Gaurav Saurav Ghosh, can you hear me? Okay, thank you, Abhishek. Thank you, Amish. So, which of the following is related to Streptococcus agalactiae? It's a very easy question. Now, let me tell you two important points. Streptococcus agalactiae is present in 25% of females all over the world as a regular commensal intravaginally. So, when a child is born through normal vaginal delivery, vagina is the birth canal. As the child is traveling through the birth canal, it will acquire Streptococcus agalactiae by inhalation because the nostrils are bigger and the nose is smaller. This organism can be inhaled and can directly travel into the brain to cause neonatal meningitis. So, Streptococcus agalactiae is a common cause of neonatal meningitis. And the same organism is capable of causing local vaginal infection and can cause UTI in the mothers also. And remember, dental biofilm or dental caries formation is a property of Streptococcus mutans, sanguis, intermedius, etc. These are the organisms who are para-organisms of streptococci. So they are actually variable group streptococci. Variable group streptococci can actually cause dental film, out of which the mutans has a very strong role. Okay, because why? They can produce dextran. Dextran formation is the virulence factor of Streptococcus agalactiae. And there is a question about parthenogenesis. They had given the explanation for parthenogenesis. The student said they had given a very elaborate question on parthenogenesis. Parthenogenesis means the female does not need male support for giving rise to the baby. So the female is capable of laying down the larva. The larva can give rise to the adult without any kind of male involvement in it, and that is a property of Strongyloides stercoralis. Very good, Saurav. And in case of ankylostoma, male and female copulation has to happen. In Tricholostichera, male and female copulation has to happen. In Trobius, male and female copulation has to happen. All these are nematodes. And in case of nematodes, nematodes are the very shrunken primitive version of human beings. Imagine a nematode to be a human being. Imagine me. If I look like a cylinder, this is how my body is. I have a body cavity called as coelom, and I'll be having a head, I'll be having my extremities. Now look at the worm. The worm will be having a proper head-like structure and tail-like structure, and this is the body cavity which contains the coelom. So like how a human being actually behaves, he can have a proper GIT, proper CNS, proper reproductive system. All the nematodes can have. What about the flukes? In case of blood flukes, you don't usually call them as male fluke and female fluke, but they're just flukes. But inside the female, the male can actually be sitting as a marsupialized activity. And when it comes to the tapeworm, you don't use the word male and female tapeworm. In the tapeworm itself, you'll be having the male components and the female components. So remember that. So okay, now these are the questions regarding diphtheria. Have a look at them. Yes, regarding diphtheria. See, diphtheria, there are many confusions surrounding diphtheria. Some students have said yes, some students have said no. See, Corynebacterium diphtheriae is the organism. Diphtheria is the disease. So when diphtheria happens, can it cause myocarditis? Yes. Is it a very common complication? No. Please remember, it is not a common cause. If at all the option said common cause of myocarditis, you cannot say that. It can cause, yes. It can cause myocarditis, yes. Assertion is true. But the reason diphtheria causes bacteremia may not be true all the while, because diphtheria is known for causing locally invasive clinical features. Diphtheria is known for causing locally invasive clinical features. Good evening, Shimona. Thank you for joining us. So, diphtheria is known for causing locally invasive clinical features. Rarely it can lead to systemic infection to cause bacteremia. But is it possible? Yes. Diphtheria causes bacteremia. That is also acceptable. But diphtheria causes bacteremia, which is the reason for myocarditis, is not the acceptable answer. While bacteremia can occur in diphtheria, it is not the primary cause of myocarditis. Point number one. The presence of the bacteria in the bloodstream can indicate a more severe and more invasive form of diphtheria strain causing systemic infection. But myocarditis itself, in case of that condition, is also due to the toxin released by the diphtheria, but not by the bacteria directly infecting the heart tissue. This is what I want you to remember. Okay. Now, in case of tuberculosis or not, some people said the question was about tuberculosis. Some people said it is not about tuberculosis, and they said it may or may not have been tuberculosis. Some people said it is tuberculosis. Some people said it is not tuberculosis. No matter what it is, what is the assertion? What is the reason? What is the assertion? What is the reason? Now, what was the assertion? Student said the sputum sample is subjected to N-acetylcysteine plus NaOH. That is statement number one. And that assertion is absolutely true. In case of a sputum sample collected for tuberculosis, it is subjected to N-acetylcysteine plus NaOH treatment. That is true. And they gave a reason. In that reason, they had said N-acetylcysteine causes killing of the commensals and NaOH causes liquefaction. This is the exact opposite of why they are used. So reason is wrong, assertion is correct. That is, NaOH is capable of destroying the commensals, and N-acetylcysteine is meant to cause liquefaction of the sputum. That is why this answer is okay. Now they asked, among the genitalia lesions, which disease is actually a multi-drug resistant disease? They had given choices. Among them, gonorrhea is the right answer. Gonorrhea is highly drug resistant, while donovanosis is limited resistance reported. In case of syphilis, rarely you can see drug resistance. In chancroid also you can see limited drug resistance being reported. Now let me show you this. In case of drug resistance, gonorrhea is highly drug resistant, and resistant issues can be seen because of multiple antibiotics, and the resistance has been seen against penicillin, tetracycline, fluoroquinolone, and even extended spectrum cephalosporins like ceftriaxone and cefixime. But what is the current treatment? You always go for dual therapy with ceftriaxone and azithromycin, which can be very helpful. Because you all have been, see, we have taught many times that gonorrhea has another strain called as penicillinase producing Neisseria gonorrhoeae. You all would actually be thinking that Neisseria gonorrhoeae is obviously multi-drug resistant, and your understanding is correct. And in case of donovanosis, it is caused by Klebsiella bacterium, which is Klebsiella granulomatis, which was previously referred to as Calimectobacterium granulomatis, and that is actually shown to have limited resistance. So it means even now you can have multiple treatment like azithromycin, doxycycline, ciprofloxacin, erythromycin, trimethoprim, sulfamethoxazole. In case of syphilis is the one condition where even simple benzathine penicillin or crystalline penicillin is still effective. Chancroid, you can go for azithromycin, ceftriaxone, ciprofloxacin, and erythromycin. And look at this question. They said HIV positive immunocompromised patient. They said there was isospora because of acid fast staining. I'm not sure what exactly was the questions. If any of you can tell me what were the lines given in the question, I'd be happy. Some students said there is immunosuppressive status and they have shown pictures of acid fastness, but they had given options of cyclospora, cryptosporidium, microsporidium, isospora, all have been given. Now let me show you this picture. It should be helpful for you. See, I have given you a combination of all pictures. On to the left, that is what you see here in all these conditions is cryptosporidium. Now, whatever you see on the left column is cryptosporidium, and on top you have a differential interference microscopy picture, contrast microscopy picture. This is the acid fast staining. Now, let us not focus on the differential contrast staining or AF staining. Just look at this. Now, what you see in this particular area is what you see as D belongs to cryptococcus. I'm sorry, D belongs to cryptosporidium. This one belongs to cyclospora, and this picture belongs to isospora belli. So I'll write it here. This one is cryptosporidium, this is cyclospora, and this is isospora. If you had an image, if you remember how the image looked, please let me know now. Please let me know now what you saw in the exam. If some students said it was oval and it was like this, then the answer should be isospora. If it is looking like this, roughly spherical, it is cyclospora. But if it is clearly like this, oval to spherical in nature, then you think of cryptosporidia. But one of these three should be given. Remember, these three are acid-fast structures because these are the cysts of cryptosporidium, cyclospora, isospora. The exact wordings are not known to me. That is why I'm not able to say which answer is the right answer. And remember, microsporidia does not produce any of these, so this cannot be the answer. Who else can be acid-fast structures? That is another MCQ altogether. For that reason, let me tell you, if it is a mycobacteria, it can be acid-fast. Apart from that, rhodococcus is acid-fast. Then you can have Legionella, but not Pneumophila. Legionella mictadae is acid-fast, and the head of human sperm is acid-fast. Apart from that, cysts of cyclospora, cryptosporidium, isospora are all acid-fast. Okay. Can anybody tell me the answer to this question? I'll wait for your answer. I just want to see how many of you can give me the right answer. Yes. So at this point of juncture, I believe that syphilis can be the right answer. Anybody else who has the better answer? Yes. Very good. Can you tell me why? Blood, RBCs, WBCs, platelets, any form. Now there is confusion. Some students said malaria. If it is malaria, malaria is generally intra-erythrocytic. So either through full form of blood or through the RBC packs will be able to send them forward. In case of filaria, because they're known for causing lymphadenitis, you will not be able to see them. Toxoplasma is known to be present inside the macrophages in the blood, so that cannot be the answer. This cannot be the answer. So according to me, the best answer would be syphilis because it can travel through almost all of them. If you have consolidated proof to say that this is not the answer and a better answer, please comment on the link below. We will try to rectify the question or edit the answers. So for all those people who have been very patient with us all these while, a big thank you for listening to this session, and please download Manipal MedAce app, and if you have still not subscribed, please subscribe to the Manipal MedAce YouTube channel here so that you will be able to watch the upcoming sessions of all the subjects for INICET preparation. So we have discussed almost all the questions that have been given to me, and trust me, I have been sitting with this particular task only on a Sunday. We had been spending the whole Sunday. I woke up at 9 o'clock, but from 12:30 I was focused on this. Till now, we have been focusing only on getting the questions, modifying the questions, refining the questions, and this is the amount of refinement we have done. But still, this may be actually recorded again and again. I mean, this may be refined again and again because nobody has told us the exact questions because the question paper is not released generally. We don't have the printed paper. For all the other purposes, for those people who have been with us, thank you very much. Let's meet you again. Have a great night. Good night. Good night. All the very best for your NEET PG exams. Let us meet once again. Yes, thank you very much, Abhishek. Thank you, Thompson. Thanks a lot. Thanks a lot, all of you. Yeah, good night. All the best. If you have any questions, you can approach me. Yes, thank you, Amish Parekh. If you have any questions, you can actually comment on this area and ask us a few doubts. If you think any of our answers are not matching your answers, and if you have solid proof that my answers are contradicting your sources,